Good morning, everyone. So the poll that I saw earlier was really very helpful for the discussion this morning. So I know and I understand that the hubs all over the Philippines are actually lacking pediatricians who can handle the HIV patients. That's why it is my pleasure to give lectures, to give updates and share our experience in UPPGH, where we have our Sagip Clinic that is for HIV clinic. So this morning, I will share with you several topics, continuing on with mother-to-child transmission. That is on the management. So yung question po kanina, actually will be discussed by me later, and then in general, the pediatric HIV. So all the references that I have here, actually you can get it from the website of the WHO, and also our local data, some of the local data. But I will not discuss much of the local data. Okay, so in HIV infection in children, it comes in different phases. So we have those infants exposed to the mothers with HIV, and then children. So these children are actually the ones who were not managed, or probably managed by the program or on PMTCT, and so they are the ones who fall on the cracks. So they are the ones now infected, maybe through maternal to child transmission, or believe it or not, these children, maybe some of them are actually sexually abused, okay, or because the children's age is those who are 3 years old and above, up to 10, and the adolescents are actually 15 to 19. Okay, so the adolescents are the ones naman, different naman yung kanila, because they are the ones like acting like adults. So they get their HIV through blood transfusion or blood infections. Okay, so maternal to child transmission, we have seen earlier that it is the transmission of HIV from an infected mother to her baby during pregnancy, labor, and delivery, and includes breastfeeding. So it refers to as vertical transmission or perinatal transmission. And most of the children, very young children, infants and young children infected with HIV acquire the virus through the maternal transmission. So prevention of maternal or of mother-to-child transmission of HIV is a term for programs, services, and interventions that was discussed earlier by Dr. Helen, and is designed to reduce the risk of your maternal to child transfer. And we hope that it's not just prevention, but also elimination, which have occurred in several countries already. So eliminated na siya. Okay, but in the Philippines, still prevention. So like in industrialized countries where women infected with HIV receive long-term combination ARV therapy, do not breastfeed, and where elective cesarean sections are safe, feasible, and commonly performed, the rate of their maternal to child transmission has been reduced to about less than 2%. In the Philippines, our latest data actually is still the 2020, but compared to a decade before, ang problema, it's still here increased pa nga yung final the transmission rates. And look at this, the final vertical transmission rate, including during breastfeeding, it's still very high at 35%. So children living with HIV not on retroviral therapy also. So and we're actually those less than 5 years of age. So the gaps is in testing of the infants and children exposed to HIV have left more than 2/5 of children living with HIV undiagnosed. So one reason is that mothers or pregnant women were not tested before they gave birth to their infants. Okay. And globally, the number of children on treatment has declined, no, probably no, due to the pandemic, leaving almost 800,000 children, that is 0 to 14 years, living with HIV, not on antiretroviral therapy. So there's now the comprehensive approach to reducing HIV infection in mothers, and then the infants, and then the young children. So the approach is doing maternal testing, and then once identified, then treat the mother, and then monitor. Okay? And also ensure that they remain virally suppressed, especially during their delivery. Then the other side would be the infant diagnosis. So there's the timely identification of infants living with HIV by testing them multiple times and ensuring that we have that infant diagnosis. Okay. Very important is the giving of your postnatal prophylaxis, which I will discuss later. And also the other arrows here are your interventions, simple interventions like promoting childhood development, like vaccination, growth and development monitoring, and feeding, infant feeding. And those also included in the prophylaxis are your cotrimoxazole prophylaxis. So infants acquiring HIV vertically by cause of transmission. Globally, as you can see, majority are on mothers who did not receive antiretroviral therapy during pregnancy or breastfeeding. Then this is followed by your mothers who did not continue with treatment during pregnancy or during breastfeeding. And then the others are the mothers who acquire the HIV during pregnancy or breastfeeding. And last will be those mothers still on antiretroviral therapy, but not virally suppressed, meaning they may have problems on resistance, drug resistance. So infant prophylaxis. So this is a WHO recommendation that ART should be initiated urgently among all pregnant and breastfeeding women living with HIV. That was emphasized by Dr. Helen. Even if they are identified late in pregnancy or postpartum, nanganak na sila, you can still test them. And if they are positive, then start the ART. Because the most effective way to prevent HIV vertical transmission is to reduce maternal viral load. So whenever possible, all efforts should be made to identify HIV-infected pregnant women early enough to avoid the need for enhanced prophylaxis. I will discuss about the enhanced prophylaxis. So, which is now, we have to now define the infants who are high risk of acquiring the disease or low risk of acquiring the disease. So the 2016 WHO Consolidated HIV Guidelines have acknowledged that there are a range of factors to be considered when assessing risks. Okay. So stratifying these HIV-exposed infants according to their risk. So before, factors such as prolonged rupture of membranes, preterm delivery, or those with low birth weight are considered as risk factors, but now are no longer associated with increased risk of transmissions when mothers are receiving the ARTs. So the critical determinant now of transmission risk in the ART era, which means in those who are having or being given the ARTs already, are their maternal viral load and duration of maternal ART. So some definitions no, on newborn ARV regimen should be determined based on the maternal and infant factors. Okay. So the use of ARV regimens in newborns include the following. So we say it is an ARV prophylaxis. So this is when we administer or give one or more ARV drugs to newborns without documented HIV infection to reduce the risk of perinatal acquisition of HIV. This is the one we give no, upon birth. Okay, so we don't know yet the HIV status of the baby because he was just born, so it's called prophylaxis. But we have the presumptive HIV therapy. Okay, this is the regimen that you give 3-drug ARV to newborns who are at highest risk of perinatal acquisition of HIV. So we give presumptive HIV therapy because it is intended to preliminary treat for a newborn who may be later documented to have HIV. So high risk nga kasi siya. But it also serves as prophylaxis against HIV acquisition for those who are exposed in utero during the birthing process or during breastfeeding, and those who do not acquire the HIV. So this I will identify who are those at risk and who are those we give the presumptive HIV therapy. Now, once they are diagnosed to have HIV or positive, the administration of the HIV therapy is now the 3-drug regimen at treatment doses. Okay, so this is now called your ART, antiretroviral therapy. Okay, so this is an algorithm, a very good and easy to understand algorithm for risk assessment at the time of delivery to help identify infants at high and low risk of infection. But actually, in PGH, in practice, whenever we have pregnant mothers who are HIV positive already and they are on regular prenatal checkup, we ask them to come to our clinic in the or in Sagip, to be seen at least 1 month before their delivery, so that we can assess them, if the baby is high risk or low risk. So, assess the mother at delivery. Okay, if the mother is a known HIV positive, but not taking ART, then that baby is high risk. So if the mother is also known HIV positive, but on ARTs already, and there's available viral load result from no more than less than 4 weeks or 4 weeks before the delivery, and the result of the viral load is more than 1,000, so that baby is still high risk. If the mother has less than or equal to 1,000, then we consider the baby as low risk. So that means there's suppression already of the viral load. Oh, sorry. If you don't have viral load available, but you know that the mother is taking ARTs already, but the mother has been taking the ARTs for more than 4 weeks prior to delivery, then that baby is considered low risk. If the mother has just started ARVs, which is less than 4 weeks prior to the delivery, then we consider that baby as high risk. Okay. And the last will be those mothers newly identified as HIV positive within 72 hours of delivery. So definitely, these babies are at high risk of acquiring the disease. So the prophylaxis, the infant prophylaxis will now depend on the risk. So high and low na lang siya. So this is actually the WHO recommendation on infant prophylaxis. The principle is that the infants of mothers who are receiving ART, no, and are breastfeeding should receive 6 weeks of infant prophylaxis with a single drug of nevirapine. If infants are receiving replacement feeding, they should be given 4 to 6 weeks. So less, lower, no, 4 to 6 weeks of infant prophylaxis with a strong recommendation and moderate certainty of evidence. Now, if the infant is born to mothers living with HIV who are at high risk, so yung kanina na red na natin kanina, the recommendation is actually going for the prophylaxis, dual prophylaxis, or for the first 6 weeks of life. Okay. Now, we have our own policies and guidelines on the use of antiretroviral therapies, and including the HIV-exposed infants. And actually, the list of these antiretroviral drugs have actually included your dolutegravir. Now, this is now for the infant ARV prophylaxis in our DOH recommendation or PMTCT recommendation. So these first two scenarios are actually for low-risk infants. So the mother has been receiving ART for at least 4 weeks, no? And either on breastfeeding or on replacement feeding for ease na lang natin, no, of simplifying, no, the term or the prophylaxis. We give daily nevirapine to the infant with 6-week duration. Okay. But those infants born to mothers with HIV who are at high risk of acquiring HIV, so either breastfed or formula fed, we start with the treatment prophylaxis or the 3 drugs. And this, the duration may be 6 weeks or longer. Infants who are at high risk of acquiring HIV, including those first identified as exposed to HIV during the postpartum period. So yung mga nanganak na, naipanganak na, but they are still in the hospital. So you can then still give them the prophylaxis of 3 drugs, but the duration is longer at 12 weeks. So this is now, again, another table, no, by the WHO recommendation. So simplifying it, so low risk of perinatal transmission, they recommend Cydovidin, but we give nevirapine, no, locally. This is just 4 weeks, but if you have for simplifying, no, we recommend 6 weeks. Locally recommend 6 weeks. For high risk perinatal HIV transmission, again, you give presumptive HIV therapy. That means you use the 3 drugs. And the presumed newborn HIV exposure, again, we give the 3 drugs, HIV drugs. No. So this is another table that would help you in the simplifying, no, age-based ARV drug dosing for infant prophylaxis. Okay. Now, diagnosing HIV in infants exposed to HIV. So that's another question earlier. So for infants it has to be the virologic assay or your HIV RNA or DNA nucleic acid test that would directly detect the HIV or the virus, no? Because in infants, the antibodies from the mother can be transmitted through through the placenta. Thus, it made that if you just use the antigen antibody test, it may detect the antibody of the mother and not from the baby. So for the clearance of these antibodies in infants is actually up to 9 months of age. But to make it really clear that there are no more antibodies in the child, no maternal antibodies in the infant, so we set it at 18 months of age. Okay. So this is another algorithm that you can that we also want to adopt, except that we cannot do the 0 to 2 days of doing the virologic test because you still have to repeat it at 46 weeks after taking off the prophylaxis. So our local recommendation is to do the testing of the HIV exposed infant at 4 to 6 weeks of age. So do the testing at 4 to 6 weeks of age. If it is negative, now HIV infection not detected, but if the infant or the child is still being breastfed, the risk of acquiring your HIV infection remains until you have the cessation or stopping of breastfeeding. So if the child is on, or if the infant is on replacement feeding, we require 2 negative tests. Okay, so that is on the 4 to 6 weeks of age, and then do regular clinical monitoring, and then conduct another virologic test or at 9 months of age. Locally, we recommend at 6 months of age. If it is then negative, 2 tests negative, then you diagnose the child unlikely, HIV unlikely, unless still breastfeeding. So if the child is still being breastfed at 9 months of age, do the antibody testing at 18 months of age or 3 months after cessation of breastfeeding, whichever is later. So if it is negative, now we label the child to have HIV unlikely. Okay. But any point in time where the child have positive test, kahit na 1 test pa lang po, we label the child as infected and immediately start ARVs. And then just do another confirmatory test. So virologic diagnostic testing is recommended for all these infants with perinatal HIV exposure at the following ages. So locally, we do the 6 weeks and then 6 months. So for infants who are at high risk, the virologic diagnostic test is actually recommended at birth and at 2 to 6 weeks. But since we start with presumptive HIV treatment or 3 drugs for those high-risk infants, then we can do the testing at 6 weeks and then at the 6 months again. So any positive virologic test should be confirmed as soon as possible by a repeat test or virologic test but definitive exclusion of HIV infection in non-breastfed infants is usually based on two or more negative virologic tests. Okay, if the virologic test is obtained at 1 month and at 4 months, or two negative antibody tests from separate specimens that were obtained at more than 6 months of age. Okay. Now, why is breastfeeding very important? Because it is the cause of your postnatal transmission. The dynamics have now shifted towards transmission during the postnatal period because about half of the children get it during breastfeeding. So programs should now strengthen the early infant diagnosis and to ensure that all these HIV-exposed infants are tested throughout the entire exposure period. We conduct the final diagnosis be conducted 3 months after cessation of the breastfeeding, or at 18 months of age, whichever is later. Why during breastfeeding also? We have in adults, the undetectable viral load actually is accepted that it prevents HIV transmission. But the research on breastfeeding women living with HIV that includes viral load data is very limited. So the evidence does exist, indicates that an undetectable viral load provides significant protection from HIV transmission. However, there are still cases of HIV transmission among breastfeeding women, so even with their undetectable viral loads. So currently, most of the high-income countries recommend that these women do not breastfeed their babies, whether they are virally suppressed or not. Okay, this is possible if they have the formula. Economically they can buy, and they have the clean boiled water that is accessible. So again, it's the risk between having the exposure or again the availability of the safe water, and if they can buy the milk formula. For example, in Africa, actually that is their main problem. Okay. So this is just a guide that shows the different stages where you can do the testing, to give the prophylaxis, and also the other routine newborn care, like immunizations, the warming, okay, throughout the life of the infant, or while the infant is in your care. So again, in the next stage is that children who are getting HIV, so those who have fallen into the cracks, their viral loads are really not that suppressed because they are not being given the ARVs. And it is very unfortunate if the child is less than 5 years of age, because this is where the time they get most of the opportunistic infections. So a comprehensive HIV testing approach for infants and children now includes that we have the infant diagnosis, but we also want to have the facility-based testing. So this is where you determine the exposure status of those infants and children attending, for example, this child coming into the clinic very malnourished without any underlying conditions. So you think of baka may HIV exposures from the mother. Those with TB, presenting with TB, okay? So in the absence of the mother, test the infant in with an age-appropriate test. So, for example, if you see that this baby is having failure to thrive or other opportunistic infections, or highly suspecting an immunocompromised state, so you can test these children. In children, what are the symptoms of HIV? It's actually the same as in the adults. Okay, so but this first stage of acute HIV infection usually is like just a flu or a common childhood illness. Okay, so again, it was already discussed earlier, the different transmission of the HIV virus. Certainly, it's from the body fluids and the blood, the semen, okay, the rectal fluids, vaginal fluids, the breast milk, okay, and these fluids must come in contact with the mucous membrane or damaged tissue or be directly injected into the bloodstream. So those who have sharing needles during sharing needles, or those who have needle pricks like that. Okay, so the next population, pediatric population, is now for those who are on their adolescent period. So we are getting more of this, like the one that you showed earlier, the video, that 10 to 19 years of age are now having more cases of HIV. And that is because of the sexual transmission, and now and also included will be a few on those who are sexually abused. Less commonly, it may spread, so mother to child during the pregnancy, birth, or breastfeeding, but can also be by being stuck with a HIV contaminated needle or other sharp objects. Okay. Now, the clinical staging of HIV disease in children, adolescents, and adults. There may be some differences, but for the clinical stage 1, it's the same. But for 2 and 3, although we don't need to see any of this, there's no requirement that 1 or 2 should be present, but anyone actually. Then you have to suspect that this child is having a secondary immunocompromised state. In one of our clinical research in our clinics, the most common presentation would be oral thrush, followed by TB. Okay. So clinical stage 1 is most of them have hepatosplenomegaly or unexplained parotid gland enlargements, or any enlargement of the glands. And then HIV clinical stage 2 are the most common, are your oral manifestations. And clinical stage 3, usually they will have the unexplained moderate malnutrition, persistent diarrhea, having persistent diarrhea, and persistent fever, unexplained persistent fever. No? Hindi lang ho TB yon, but it can be HIV. And definitely, if they have pulmonary TB or a case of a very severe recurrent bacterial pneumonia, then we suspect that they may have HIV. So for the stage 4, these are the most advanced cases, those who are actually coming in due to pneumocystis pneumonia. Most commonly, majority of our patients are having severe wasting stunting or severe malnutrition. But actually, their intake is not compromised. So talagang bakit kaya sila nangangayaya? And then they would present with several severe bacterial infections, okay, and the extrapulmonary TB. Okay. This is what I told you about the esophageal candidiasis, no? And this is just a picture of a wasting, no, of a HIV case in children. So the rapid diagnostic test for HIV serology. So we do serology for children 18 months and above. So again, pag HIV exposed infants, you do the virologic testing. But the serologic testing for children 4 to 18 months of age can be done also, but you have to repeat it and do a confirmatory test. Okay. If the virologic test is not available. So the timing of virological tests, again, as I've told you, this is used for those infants born to HIV infected mothers. Okay, so it's the strong recommendation is do the virologic test. For adolescents, definitely they can use your antibody tests. So the rapid test is very much the test that we can use. And once you have a positive test, then you can start. The recommendation is, again, start your treatment. So for those who have indeterminate test results, and we have several of these. So because we're using the rapid test, no, or the serologic test. So if it is positive, then manage, no, with as a positive test. But if it is indeterminate on the first sample, then take another sample. If it is still indeterminate, then request a new sample within 4 weeks. So again, ikot na lang siya ng ikot. Okay? But if the indeterminate turn to be negative, then manage as in negative. And once positive, then it's positive. Okay? So when to start ARV? As in all populations, adult, pregnant women, breastfeeding women, adolescents, children living with HIV 1 year old to less than 10, and those infants diagnosed in the first year of life. Again, they are all to be started once you have the test positive, regardless of your CD4 count. Okay, so that is the rapid ART initiation. So it should be given as soon as they are diagnosed. Okay, so the timing, not just some of the it's for special populations. Now, those who are for example, the patients came into you because of the severe TB, no, and then when you do the test, they are positive for HIV. So ART should be started as soon as possible within 2 weeks of initiating TB treatment. So you start with the TB treatment first, and then 2 weeks, after 2 weeks of TB treatment, then start the ART. You know, before this was actually 8 weeks after initiating TB treatment. But sometimes, nauunahan tayo, no? So they have several, by evidence that it can now be lowered to 2 weeks so that you can start the ARTs because the underlying naman talaga is the HIV infection. Except when there are signs and symptoms of meningitis. So for meningitis, still the 4 weeks. So for those naman who have been identified or and showed that they have cryptococcal meningitis. Again, this is for the meningitis. Immediate ART initiation is not recommended. Okay, you start the treatment for the cryptococcal meningitis, and the being given initiate the antifungal treatment first, and then start the ARV 4 to 6 weeks from the initiation of your antifungal treatment. The reason is the iris, no, that may develop, although it's very, very rare. I have not seen a case with iris yet, no, even if we have started with, we follow this, no, even we have started the ARTs. And those with histoplasmosis, ART should be initiated as soon as possible, okay? But for those with CNS involvement, okay, it's not suspected or proven. Again, if with CNS involvement, you may delay the starting of your ARTs. So this is the table. I hope that for the questions earlier, no, what to give. So for neonates, no, for these are actually the preferred first line regimen is actually what we recommend for the infants also. But we give, depending on the availability of the abacavir, no, we give Cydo, Lami, and Nevi because raltegravir is not locally available. Okay, so and then now we are, for example, if the child is now HIV positive, no, we are transitioning to giving of the dolutegravir. So again, it's a 3 drugs. Okay, so dolutegravir is a new drug, okay, and is now indicated for infants and children age 4 weeks to 12 years. So we don't start with dolutegravir as the infant prophylaxis, but we can shift them if they turn out to be positive. Okay, so we are now starting with those who are children who are really positive now for the HIV, because it has advantages, no? Because of the efavirenz and or nevirapine resistance, which is very high. So we base it on the adult data, but we also have several cases of children having efavirenz and nevirapine resistance. So we shift them now to dolutegravir containing regimen. So dolutegravir has other advantages, including fewer drug interactions, okay, and also the higher genetic barrier to developing drug resistance and activity against your HIV-2 infection, okay, which is actually naturally resistant to your efavirenz. And the availability of dolutegravir as a once daily generic fixed formulation, that is, we give them now to children 10 years older or above, or 40 kilograms and above. Okay, so parang adult na rin sila. But we also now have the available dolutegravir solo, no, tablets that is dispersible. So mas madali na ho siyang gamitin. So as of mid-2020, it has been approved for infants and young children. So, but since we have limited experience with dolutegravir among children, no, we are looking into the safety and efficacy, no, of this drug in children. So treatment monitoring, you do the routine viral load monitoring for detection of treatment failure. By the Telehealth has covered now the viral load testing, so libre siya, but every 6 months. So that's why we follow this. So we do the viral load testing every 6 months. If it is undetectable, then just continue. But if there's increasing viral load, then we do an adherence counseling, kasi yun yung most common problem with giving of the drugs, no? Hindi naman talaga because the drug is ineffective, but because the drug is not being taken, especially in these children and adolescents who have guardians giving them the medications. No, sometimes the guardians will forget, no, to give them the drug, or pag teenager na, the problem naman is the rebellion. Alam niyo na yon, no? That they don't want to take the drugs because of the, sometimes it's not really just the stigma, but because you have to take it every day, no? So the responsibility is on their own already. So and they are not adults yet. So nagkakaroon tayo ng adherence problems. Okay? So that we have also the cotrimoxazole prophylaxis, and this is being given now, no? Short course na ho siya ngayon. If you know that ito yun, yung meron na siyang starting and discontinuing the cotrimoxazole prophylaxis. But for us in settings with low prevalence tayo, but we have both the malaria and severe bacterial infections, so it may be discontinued for those older than 5 years who are clinically stable with evidence of immune recovery, that is the CD4 count, and then the suppression of viral loads. But those infants exposed, we initiate the cotrimoxazole prophylaxis together with the prophylaxis drug at 4 to 6 weeks, and then stop it if the HIV infection is excluded already. Okay. So the future is that although we have more, we have good coverage for maternal to child, but the gaps still exist because we need more effective counseling and even preparation of women testing positive for the HIV while they are pregnant. Okay, and they have to start the ARVs. Okay, so we also want better data systems, so to enable these women and also for the caregivers, no, to be able to provide for the drugs. There's also, no, the rapid expansion of a suggestion of the point of care early infant diagnosis, and then also integrating the testing into other healthcare services, and like those who have like just giving the immunization. No? Okay, so I hope I have answered most of your questions, and I have equipped you with kasi yung sa poll kanina, di ba? We equip you with the data, and I'm now ready to answer more of the questions. Thank you.